Hey, this is Joe H. I'm here with my buddy, Dr. Brent Laing. And what have you got there in your hands, Doc?
This here is a new CarePath system. It is a system designed to allow us to, in real time, in a remote setting, such as the patient's home or in the clinic, or even in a hospital setting, monitor urine output with great accuracy.
I think you've vastly undersold what you're holding in your hand.
Really?
Yeah. So, truth be told, I've had the chance to work with him for a little while, and we're working on telling his story. And what he's holding is the first and only remote patient monitoring system for urology.
That is correct.
So you delivered 7,000 children or so.
At least.
You no longer practice OBGYN.
No.
But along the way, you thought, we need this thing that I'm holding in my hands.
Well, during my 35 years of practice, most of it, especially the last 15 years, was spent in the field of urogynecology, which is a specialty that deals with bladder dysfunction and pelvic support disorders. And the thing I faced every day, multiple times, was I had to get an objective, accurate feel for the patient's symptomatology. How exactly was her bladder functioning? So I needed voiding data, and that was something that was almost impossible to obtain with the current technology.
What is the current technology?
Current technology means I give the patient a hat, a plastic container that fits in the commode, and they have to then void into that and measure it right on a piece of paper. And the problem is the vast majority of patients can't sit by their bathroom for 3 days and do that. So compliance is poor, accuracy is even worse because they'll skip parts of the day, they'll miss voids, and they'll fill it in retrospectively. It's called hoarding. They'll build up the information and they'll go back and put it in, usually in my waiting room.
Kind of like, oh yeah, I think it was 2 in the morning.
Yeah, and I think I voided this much, or I think it was this issue. So that doesn't give me information I need to make an accurate diagnosis. So over the course of 35 years of practice, I dealt with this problem thousands, tens of thousands of times. I got to the point of frustration saying somebody has to solve this problem. There has to be a way of doing it better.
It does seem like such a chasm between what is still today, so we're talking in December of 2019 here in Tennessee, thanks for the invite, and this isn't on the market yet.
No, it will be the second quarter of next year.
And so, for as long as you've been in practice, the best alternative to having somebody pee naturally on their own schedule into a device that, as I understand it, collects the data of the flow, the duration, the time, the volume, and reports it up to the cloud and goes right to the doctor's reports.
And from there it can be used, any sort of report, analyzed in any manner that the healthcare provider, the urologist, the urogynecologist, the gynecologist wishes.
In the absence of that, I had 2 choices. I could pee in a plastic hat, look at the side of the thing, write down how much I think that is, pour it out, wash the thing, put it away. I'm certainly not taking that to work.
No.
Or the restaurant.
No.
So later on I say I went a little or a lot, basically. Right. I went to the bathroom and I really had to go, and that's your data.
If you really have to go at home even, you haven't got time to take out this equipment, put it in the commode, and get it positioned before you have to void. So many times you just wouldn't use it. So we needed a way to be able to capture accurate, objective voiding data that was completely intuitive, completely automatic, that required almost no interaction with the patient except to hold it in position and void through it.
Now, you know I'm a little out of my element, but I understand that there's a big, expensive piece of equipment called a uroflowometer.
You can get a urine flow meter, which is based on the weight of the urine, and the one I would have in my bladder lab is going to be somewhere around several $1,000s and require a fairly extensive setup. So you can do a uroflow, for instance, for a man with maybe a prostate issue in the office.
Right.
The problem is
that's one sample.
One sample.
Right.
Done under very unusual or natural circumstances.
So I'm going to the urologist, so I'll be sure not to go for the next hour or 2, so that I have enough.
Yeah, but 2 out of 3 times
I don't have enough.
Or you're just not able to void because of inhibition in the office. So what you're getting is a very unnatural look at what you think is his voiding pattern. At home, he can get up in the morning, he can use it in the afternoon, he can go several times during the 2-week period, and we get a whole panorama of what his voiding function truly is. And we get it exactly in the same environment he's voiding usually. So it's a completely natural snapshot of his bladder function. That's not possible without it.
It's funny. As a marketer, I'm in charge of telling stories, and yet the understated delivery I have right now belies how enthusiastic I am about this, which sounds like copy for this camera. But the fact is, there was no way to do this before. And this is because of the advent of remote patient monitoring?
Exactly. New technologies allow us to capture that data easily, to send it to the cloud, and have it then used from the cloud in the form of reports. And before it was a
possibility.
Before it was possible, people just didn't do it.
So you want to sit here for a sec?
Yeah. You would ask the patient, what her symptomatology was, or his, and they would try and remember, and the reality is people do not remember what they do in the bathroom.
Right. I want to sit in the good chair.
You got it.
All right, good.
You got it. So that's not something that people normally remember.
I know that since you're the client, you should have the good chair, but
No, that's good.
It's been a long day, and I have to fly out to Tennessee.
And the really important part is we were basing our diagnosis, basing our expensive management decisions or invasive management decisions on information that most of the time was incomplete, or even worse, incomplete and inaccurate.
How big a deal is getting it wrong in this field? Or I told you I think I peed this much or that much. If I really peed 100 cc's, I have no idea how much that is, of course. Maybe that's like a gallon, I don't know. But I actually only did 70. Is your diagnosis going to be so different that, oh, I would never have put you on that medicine, or we never would have taken an MRI?
Well, if a person even had that degree of recollection, then the need is not as great. But the reality is what they'll say is, I think I went 4 times last night, or maybe I went 2 times, and it was kind of like a normal amount. You know, you're not going to get somebody saying, yeah, I was sat there and I avoided 100 cc's. They're not going to have any idea. So we get really sort of a general idea, yeah, I'm going a lot, doc. Or I think I'm going less than I should.
Okay.
In terms of the amount.
So what do you do with that information?
Well, you don't do anything. I mean, you try to make a diagnosis. You may do what we call bother indexes, which is a form you fill out that gives you a score that says, okay, your bladder is bothering you to a certain degree. And especially if you're a man with a prostate issue, we'd use what's called a prostate symptom score. The problem with that is it doesn't give me the data I need to really use to make an accurate diagnosis. I know it bothers you, and from the score I can tell, the IPSS score, I can tell, there may be a prostate issue here, but it's not definitive.
So I'm in my early 50s. I haven't had to worry about this issue just yet.
But you will eventually.
How old will I typically be when I start to say, I think I have a problem?
Yeah, over 80% of men in the 70 group, in age 70 and above, are going to have issues with their prostate, resulting in lower urinary tract symptomatology that bothers them. You're 50, so you're not quite there yet. When you get to be 60, you're up to probably 60+%. So it's a very common issue.
And my issue is going to be?
You're going to have a problem in terms of emptying
Going.
your bladder. You're going to have a problem getting started. You're going to find you have to strain sometimes. You're going to find you're getting up several times at night, which is probably the worst
And
thing.
like I never feel like I've completely emptied my bladder.
Yeah.
Like I feel like I always have to go.
Yeah, so there's a frequency to it, there's an urgency issue, and there's what we call nocturia, which is going at night.
Right.
And all of those issues over time become extremely bothersome to the patient.
I sing in the chorus. My section leader, Bill, always had his phone go off at 7 o'clock, so I knew it was time, A, for his prostate medication, and B, it was time for us to get on the risers. And he recently had an operation.
Yeah, it's a very common concern, but it has a great impact on quality of life for the patient, be it male or female. Obviously, the women's issue is different. It's going to be more likely the overactive bladder. But even in the man, there's a dozen different reasons that you might come in and give me the same symptomatology. And unless I know the amount you're voiding and accurate data on how often you void and what those voids are like, I can't tell which of the 12 possibilities it might be. Do you have an overactive bladder? Do you have a prostate issue that's causing obstruction? Do you have inflamed prostate issues? Do you have an underactive bladder? These are all things I got to sort out when I see you. The best I can do is go off what you tell me you think you remember about your bladder function. It's not a very accurate piece of information to allow me to make an accurate diagnosis. And I'm going to make decisions. Okay, let's put you on medication, or let's put you on surgery. I don't want to take you to the operating room, operate on you, and then come back and you know better, because I didn't get the diagnosis right at the beginning. So I'm treating you thinking, well, from your symptom score, I think that you have moderate to severe obstructive disease. But really what you have is you have an overactive bladder with a mild degree of obstruction. My symptom score is not going to tell me that. I need this. I need the information on how often you void, what your void looks like in terms of its pattern, what amount you voided, and the sort of the symptomatology around those voids. With that, I can quickly sort out, well, okay, he really is more of an overactive bladder issue, and he requires going on this medication to calm that down. His degree of obstruction is actually fairly mild. He has normal flow rates, so his obstruction is a fairly mild process. So I don't end up treating you with surgery or wasting your time on medication based on my inability to get the objective, accurate voiding data I need to make the proper diagnosis. And I don't keep you on it when you're not getting better, because I can't tell you're not getting better because you can't give me the information I need to say, okay, we've improved. With this, I can send you out in 3 months and say, how are we doing? You come back and I can compare the two and say, okay, here's where you were before treatment, here's where you are now, and we have a 60% improvement in all the parameters.
affectionately for our audience, my loquacious friend here would be happy to talk for a lot longer, but you have other things to do today. So I want to wrap with two things. One is remote patient monitoring means you can do it in other places that you normally wouldn't, but this is going to offer a degree of accuracy that no technology can offer.
There's nothing in existence that will give you the accuracy of the CarePath device in the ambulatory or home environment. You can't bring a full bladder lab gravimetric uroflow meter into your bathroom. There are potential to bring in devices about the size of a kitchen blender that you can use and track that, but the problem is they're not going to give you the data you need to do avoiding diarrhea. And I want both. I want to know your uroflow pattern, and I want to know your voiding data over time. And the only thing that allows you to do that is a CarePath device. There is no other technology or device in existence.
I was saying this earlier today. I admire him not only for his sartorial choices, but you've delivered thousands of babies, and somehow you figured out engineering, design. This is not his first medical device. As I understand it, you sold your last company to Medtronic some years back.
In 2014.
And you've already conceived your next invention. Sorry, he's not taking investors at this time. Sorry, I won't be able to invest in it myself. My parting question for you is, we're looking into the future now. This has widespread adoption. What do you think is going to be the difference in care? There'll be more accurate, yes. But do you think we're more likely to see fewer surgeries because so many were unnecessary? Do you think we're going to have more because so many went undiagnosed? Are we going to have more people on medication, fewer people on medication? Do you have a guess?
I think we're going to see more people managed appropriately. The problem you have now is that people come in and they're diagnosed maybe inaccurately. Maybe the treatment they're on is not being monitored or appropriately adjusted because of lack of information, and so they get discouraged and they don't follow through. And there's what we call patient attrition. They begin with the first visit and they don't follow along to the point of resolution.
So they just suffer.
They just suffer. So that's one of the problems. The other problem is it's very expensive. That wandering around therapies is very expensive. Some of the therapies are surgical or invasive and also involve a significant expense. So you want to avoid that in the wrong patient. If they're not going to benefit from it, you want to avoid doing it on them. So I think that's another issue that will go. We also have to be very cognizant of healthcare cost. So this allows us to take that care, the triaging part of it, and back to a community-based clinic at a mid-level provider, and allow her to manage a number of, a large percentage of patients that now go to the urologist, but manage it at the community level at a much lower cost of the system, and free up the specialists, the urologists who are in desperately short supply and getting worse in terms of shortages in manpower. Allow them to do what they're trained to do, which is, invasive investigations, third-line therapies, and
push down part of the diagnosis part.
Absolutely.
To free up what is, as I understand it, a greater demand as we age and
a fewer
decrease in supply of urologists.
Yeah, most urogynes and urologists are over 55. So we are going to see...
Why aren't we replenishing that? You know what, I promised I would let you go. That's for another video for another time. That's Dr. Brent Laing. I'm Joe Hage. Thanks for talking.
Thank you.
Really impressive. I'm really excited to have even a small part in your success here.
Thank you very kindly.
Thank you, Brent.